Meeting Personal Healthcare Needs in Primary Care, a response from the athletic training profession. An applied research project by Wade Green. Faculty advisor, Dr. Eric Sowers. In partial fulfillment of the requirements for the degree of Doctor of Athletic Training. Andrew Taylor still can be seen in these rough sketch drawings attending to his patients. He is the father of osteopathic medicine, and he championed a whole person approach to healthcare. This was common to the doctors in the 19th and early 20th centuries, who were often the only resource for their patients' health. They treated a wide variety of conditions, often caring for patients in their homes. Personal and established relationships with patients and their family members were common, and physicians were regarded highly for their intimate knowledge of their patients and their personal histories. Today, things are much different. There is a growing shortage of primary care physicians, and care is often delivered in a fragmented, high-expense system. Our current problem is not new, but was brought about by well-intentioned reforms to medical education and the provision of medical care. Let's take a more focused look at how we got here. In the late 19th and 20th centuries, medical education was largely based on an apprenticeship model. The apprenticeship model was unstructured, with no standards for deciding who was ready for independent practice as a physician. Abraham Flexner authored his report, Medical Education in the United States and Canada, at the behest of the Carnegie Foundation for the Advancement of Teaching. The goal of this report was to distribute as widely as possible the best physicians so distributable. According to Flexner, the foundation of medical education was the sciences. Many scientific instruments, the microscope, the thermometer, the stethoscope, biochemical reagents, were thought to increase the physician's range. The first and second years of undergraduate medical education will be spent in the laboratory, with the third and fourth spent in the hospital. More rigorous standards for educational programs would hopefully attract better students and eventually better physicians. The combination of science and patient care was intended to produce highly skilled clinicians and assuage public dissatisfaction with medical care. But where would such high quality care be provided? As the students impacted by Flexner's reforms became doctors, scientific advancement became increasingly rapid. It had been acknowledged that the discipline of medicine could no longer be adequately stewarded by a single physician. The development of science and technology was accelerated by World War II. Many medical students began to declare their intention to practice in a group practice or hospital. Since many of the emerging technologies were simply not affordable to the solo general practitioner, care began to shift away from the independent generalist toward the hospital. The hospital began to develop the perception as the place in which ideal medical care should be provided. Medicine found itself in the midst of a shift towards specialization. Patients responded to the increased availability of specialist physicians and available technology by seeking care in hospitals, creating the home-to-hospital movement. It is also worth examining other societal factors that precipitated this shift. Hospital privileges were connected to residency training and status as a specialist. Residencies in general practice did not yet exist, and as a result, many of the patients receiving care in hospitals were simply removed from the general practitioner's patient population. Additionally, specialists were often provided government subsidies for residency training and were also kept off of the front lines during World War II. The emergence of medical insurance programs that provided payment for hospital-based services were becoming increasingly more common. All of these factors exacerbated the shift towards specialization and left the general practitioner without recognition and prestige in the evolving medical landscape at the time. A response to this problem would come through the American Medical Association. Despite a lack of consensus, the decision to pursue specialization in general practice was reached in 1965. The Citizens Council on Graduate Medical Education was commissioned by the American Medical Association to begin studying this problem. The type of physician that was to be created through specialization in general practice was one who was expert in care that was coordinated and continuous. The focus of this physician was not on simply providing the best care. It was on providing the best care and arranging for the most appropriate care to be provided by other physicians as well. The larger purpose of pursuing specialization in general practice was to create a new dimension to medical practice. In order for that new dimension to find context within the current climate, it was propositioned that the Commission on Graduate Medical Education be called upon to review residency accreditation standards yearly. Group practice was also proposed for the residency trained generalist to ensure role and function within the practice. The content of education was not entirely certain, but it would be necessary to begin to study the characteristics of care provided by this new physician. That would be accomplished by identification of attributes and the publication of reports over a 30-year period. John Millis was a researcher and the chair of the Citizens Commission on Graduate Medical Education, which also earned the nickname the Millis Commission. He led the Citizens Commission. He led the Citizens Commission's articulation of the challenges facing the generalist physician and solutions to those challenges. An important aspect of the Millis Commission report was the development of a new name for the generalist physician, as generalist physician had lost its prestige. Personal physician was problematic because all physicians had personal relationships with patients. Family physician implied care for an entire family, but this was not always the case. Additionally, there was no specification for the type and level of training of the family physician. First contact physician was problematic because patients did not always see generalists first. Comprehensive care physician was an awkward title. The Commission finally settled on the term primary physician. The Millis report would serve as a foundation and a catalyst for the current understanding and definition of primary care as it is known today. Although the term primary medical care was first used in the United States by White in 1961, the concept of primary care had not yet entered the national consciousness. As the role of the primary physician began to be explored, the socio-political climate on healthcare gained a significant amount of influence. The Millis Report of 1966 promoted group practice for physicians. The World Health Organization, or WHO, held a different set of core beliefs about the health needs of humanity, stating that the hospital-based system, now common in the United States, did not translate well into the settings of developing countries, where non-clinician community health workers often delivered care with little to no education or training. The member countries within the WHO met at Alma Ata in the former Soviet Union in September of 1978. This meeting resulted in the Alma Ata Declaration, which called for primary health care to be a top priority for all countries. The Alma Ata Declaration advanced the idea that technology use in healthcare should be appropriate to meet the needs of all citizens, discouraged the over-specialization of physicians, and presented healthcare as an avenue to improve living conditions. Earlier in 1978, the Institute of Medicine, or IOM, published a report that explored the attributes of primary care, which would be defined and expanded upon to the current day in discussion of primary care. The first narrative definition of primary care would come from the Institute of Medicine in 1996 with their report, Primary Care, America's Health in a New Era. The late pediatrician and public health researcher Barbara Starfield would carry the study of primary care into the current day, as her work would serve as the foundation for discussion on primary care for clinicians today. The 1978 report of Manpower Policy for Primary Care enumerated 5 attributes to the achievement of primary care. Those describe care that is accessible, coordinated, comprehensive, continuous, and accountable. Accessibility involves removing spatial, temporal, and economic barriers to care. Coordination of care includes coordination of care provided by specialists, arranging contact and referral between the patient and the specialist, seeking the opinion of specialists, and explaining diagnosis and treatment, and ensuring that the plan of care is congruent with the patient's economic situation and personal desires. Comprehensiveness of care refers to the willingness of the primary care team to handle the great majority of health problems arising in the population that it serves. It's important to note that the comprehensiveness of care can be limited to a specific age group or sex, but that primary care providers should be able to handle the majority of healthcare concerns that arise within that group. Continuity of care generally involves having the same provider for care for a patient from one visit to another. Continuity involves the transfer of information that is consistent from one provider to another. Continuous care at its best should also be longitudinal, in that the same source of care is utilized over time. Accountability is also included and represents patient education regarding risks and adverse effects of treatment to help assist patients in making the most appropriate decisions. In 1996, the Institute of Medicine issued a narrative definition of primary care that is still used today. Primary care was known as the provision of integrated, accessible healthcare services by clinicians that are accountable for addressing a large majority of personal health needs, developing a sustained partnership with patients, and practicing within the context of family and community. If the new primary care physician was to create a new dimension in medical care, what would that look like? Can competence to provide that new dimension of care be measured through a written exam? Competency-based education has been the most recent solution to ensure preparation of graduates and promote clinical competence. The Accreditation Council on Graduate Medical Education, or ACGME, has enumerated 6 competencies that residents are to be assessed in. Those are patient care, medical knowledge, systems-based practice, practice-based learning and improvement, and interpersonal and communication skills. A challenge in implementing these competencies has been a lack of shared understanding. Additionally, agreement on what a resident looks like in clinical practice differs among preceptors and faculty members with different expectations. The milestone was introduced as a solution to characterizing the progression of mastery within a specific competency. A milestone is a significant point in development that provides a description of development as mastery is obtained within a competency. The milestones are based on the Dreyfus model of skill acquisition and are advantageous because both the performance of skill and the demonstration of knowledge are both contained in each stage. According to the Dreyfus model, increased experience and mastery transform skill. Skill transformation then brings about a change in performance. There are 5 levels that have been described within the Dreyfus model. Level 1 corresponds to a novice learner. Level 2 corresponds to an advanced beginner. Level 3 to a competent learner. Level 4 to proficient. And level 5 to expert. The use of a milestone model has been useful in the education of residents, as Friedman and colleagues noted that this model led to more discriminate analysis of skill over the course of a 3-year residency training program. To date, milestone projects have been completed in all 28 specialty areas as listed by the ACGME. It is fully expected that specialties will continue to move forward with milestone methods of evaluating residents, as they have been required to document the progress of residents. Family medicine, internal medicine, pediatrics, psychiatry, and obstetrics and gynecology were all noted in the Mills report as relevant specialties for primary care. Family medicine and internal medicine are focused on for the sake of this review of the ACGME milestones. Family medicine has maintained itself as a specialty to advocate for and promote the importance and characteristics of primary care. A key characteristic of the internal medicine milestone project involves interprofessional collaboration with other specialties. The internal medicine resident is given a high level of independence in both interprofessional collaboration and consulting for various problems. In contrast, the family medicine milestones note the importance of disease prevention and health promotion, as well as development and sustainment of partnerships at both the patient and community levels. In primary care and athletic training, disease prevention and health promotion are notable areas of emphasis. Preventing disease and promoting health involves intervention not just with the individual patient, but also in the environment that they interface with on a daily basis. Public health is defined as what we do as a society to ensure the conditions in which everyone can be healthy. Adequate medical care and evidence-based health information can be disseminated in the clinic to patients, but in order for that to impact society, that information and care must be applied outside of the clinical environment where access is equalized, at least in theory. The CDC has promoted 3 buckets of prevention: traditional clinical prevention, innovative clinical prevention, and total population or community-wide prevention. Athletic trainers are involved in each on a daily basis. As we participate in each bucket, we make recommendations for prevention to individual patients based on traditional clinical recommendations, perform innovative strategies for prevention, such as movement screening, and design and promote educational materials for mass dissemination, or carry out the recommendations of a position statement. The main metric for improving the health of outcomes of the population has been identified as the health indicator. Healthy People 2020 is a campaign based on the recommendations by the Federal Interagency Working Group, and it is this report that identifies those health identifiers. 26 health indicators are listed within this most recent 2014 report, detailing progress on those health indicators since their original publication in 2011. Out of those health indicators, there are 8 total that have shown little detectable change since 2011. The chronic care model was developed by Wagner to address the health needs of patients with chronic conditions. The patient who was being seen by the primary care physician for a chronic condition often received work to do from the physician. This is healthcare work or treatment that can result in a treatment burden. A recent systematic review and thematic analysis of the application of the chronic care model to patients with multimorbidity found that the CCM or chronic care model may not adequately address the practical needs of patients with multimorbidity or ease the treatment workload experienced by those patients. This results in a choice that the patient must make between necessary life roles and tasks and pursuing that appropriate care in a timely manner, which may negatively affect health. The integration of primary care and public health may lead to better tools produced for treating chronic conditions in the environment with collaboration and training. Ideal integration includes the goal of expanding the care of the patient outside of the traditional encounter and into the patient's environment. If that's the case, then a requisite level of knowledge and self-determination on the part of the patient about what actually constitutes health is necessary. A framework for understanding how that level of education, awareness, and participation could be made manifest is P4 Systems Medicine, or P4SM. The P4 stands for medical care that is predictive, preventative, personalized, and participatory. Preventative medicine involves the potential utilization of genetic markers and specific tools to estimate the patient's response to treatment or injury. Preventative medicine has been described as an approach to prevent a problem that has been predefined via the individual collection and analysis of a patient's family, personal, and genetic data. Imagine adding genetic testing to a PPE to look for potential risk factors for disease or injury. Personalized medicine involves utilization of all available patient information, genetic, personal previous and current history, and family history to formulate treatment plans for presenting clinical problems. Participatory medicine involves the patient by turning he or she into an educated consumer of information regarding their health. It also provides education on health conditions and treatment and gives the patient the primary responsibility for carrying out the plan of care. P4 Systems Medicine seeks to provide personalized and comprehensive information to patients to allow them to be treated while minimizing waste and harm. Additionally, the patient is given primary responsibility for carrying out the plan of care in the environment and knowing environmental risk factors based on personalized data. Integration between primary care and public health then becomes an active process between the patient and the environment they interface with. P4 Systems Medicine is an emerging idea within primary care and even within athletic training. This will be something that will be a continued area of research moving forward. Athletic trainers have been conditioned to work in integrative environments, and we have substantial experience in engaging stakeholders for public health problems specific to our population. Part of the structure for addressing behavior change has come through models such as the socio-ecologic framework. This is a framework that attempts to address health behavior change by addressing educational interventions at the interpersonal, environmental, and the society and policy levels. This most notable example is of the SEF, or socio-ecologic framework, is within concussion education. In order to expand the reach of our expertise with increased relevance for all Americans, the role of the athletic trainer as an agent of behavior change needs to be explored. While exercise prescription has been identified as an obvious tool for impacting the health of the population, the recognition that those tools can be applied to the healthy and with slight modifications to those with chronic conditions such as diabetes type 2 and cardiovascular disease may not be fully appreciated by many athletic trainers. Craddock and colleagues provided a review of various health behavior change interventions that could possibly be utilized to increase competence with recommended physical activity guidelines. The health behavior model, theory of planned behavior, and others were reviewed with the overall intention of applying them to patient encounters to remove barriers and facilitate habits of regular exercise. The athletic trainer's experience in coordinating care and modifying activity may also be useful in decreasing the overall possibility of treatment burden for patients to assist in diminishing the stress associated with balancing self-care for chronic illness and basic life tasks. As the athletic trainer works to facilitate a role as an agent of behavior change, a quality improvement approach to addressing health needs will be necessary. The QI approach involves identification of a problem or gap in quality of care, a specific plan to address the problem or quality gap, and evaluation of the results of the plan to determine directions for future change. This has also been referred to as the Plan, Do, Study, Act cycle, or PDSA cycle. Shanley and colleagues utilized a QI framework in a cohort of approximately 67,000 student athletes. The informed use of patient data resulted in prevention and strengthening programs to prevent muscular injury, shoulder pathology in pitchers, and allowed them to make recommendations for safe return to activity after ACL reconstruction. The programs based on a QI initiative also resulted in a $250,000 reduction in secondary insurance claim costs. The use of QI initiatives may provide access to health care for those who would not normally have access. Additionally, as QI initiatives are implemented in the setting of population health, a regular source of care is created by the athletic trainer, and a population-based effort is translated into a one-on-one patient contact. In order to build the case that the athletic trainer can serve as a primary care provider, the following three factors need to be explored: the application of primary care attributes into an athletic training context, the potential impact of the current healthcare climate, and the skill mix that the athletic trainer contributes to the primary care team. When an athletic trainer provides access to care or needed referral for a patient with limited means or a point of entry for a patient without access to care at all, the primary care attribute of accessibility has been realized. Comprehensiveness generally relates to the expectation that the athletic trainer is able to address a variety of personal healthcare needs for any number of undifferentiated patient concerns. It's highly plausible that a single day in an athletic trainer's clinical practice involves undifferentiated concerns for several organ systems and pathological entities. Coordination of care involves ensuring access to the appropriate specialist, interpreting and explaining lab or imaging results, or triaging a patient's problems to ensure that they are seen by the appropriate provider in the most expedient order. Accountability involves meeting the health needs of the patient in a manner that is ethical and governed by the patient, applicable governments, and peers. Efficient use of resources also encompasses accountable care. Continuous care is that which is managed by an individual or group of clinicians over a sustained and considerable period of time. Athletic training is unique in that patients are often retained for a period of months to years in the more traditional practice settings, which allows for a dynamic and comprehensive view of the patient, their personal medical history, and their needs. The reframing of the athletic trainer's point of view to see their daily interactions and tasks as primary care attributes is a paradigm shift, but it is not out of reach. Hajart has commented regarding the implications that previous healthcare reforms have had on the practice of athletic training. Specifically, Hajart states that athletic trainers may be well positioned to succeed in an accountable care organization. This type of environment, where incentives are given for high quality, low cost care, could be advantageous for the athletic training profession. Starfield reports that those nations which have highly developed systems of primary care typically rank high in cost containment when compared to those who do not. Additionally, the United States was characterized as having a poor orientation towards primary care as of 2004. More patients have been filtered into primary care clinics due to an increased emphasis on primary care and the continued growth of HMOs, further substantiating the need, but exacerbating a long-standing shortage. With the projected primary care physician shortage estimated at 91,500 by 2020, creative use of healthcare resources will be required. It has also been proposed that the athletic trainer could be very well suited to assist in addressing that shortfall. In order for the athletic trainer to fulfill such a role in team-based primary care, skills in virtual consultation, extended hours, and a walk-in care model may be utilized to ensure expanded access and cost savings. Perhaps most importantly, an increase of one primary care physician per 10,000 people resulted in better health outcomes. This is the primary point and most important aspect of increasing access and number of clinicians available. Advancing the idea that the athletic trainer can serve as a primary care provider requires actual data that providers other than physicians are engaged in primary care. Although this may seem obvious, literature on skill mix and task shifting may provide insight that care processes within primary care are changing. Skill mix has been conceptualized as the presence of healthcare providers of different disciplines within a practice setting. Task shifting has been operationally defined as the surrendering of tasks traditionally performed by physicians to non-physicians, traditionally nurses and physician assistants, with the expectations that those providers have the capacity to complete them. While task shifting has not been formally discussed within the athletic training profession, apart from the direct supervision of a physician, investigating the value and hiring patterns of athletic trainers within ambulatory settings may provide a possible metric of an emerging skill mix within the profession. Frogner and Westerman conducted a nationwide survey of athletic trainers employed in ambulatory care settings. Of those athletic trainers surveyed, 60% practiced in a multi-specialty clinic. 27% of those multi-specialty practices were described as working in primary care. Interestingly, the age groups most commonly served by athletic trainers in ambulatory care settings were under the age of 18 and over the age of 65. The athletic training practice domains resemble the family medicine subcompetencies through similar language, but also promote wellness and health promotion. While the language is more broad in the family practice milestone document, the athletic training domains appear to represent more focused perspectives on the role of the primary care provider. The Practice Analysis 7th edition utilizes the term primary healthcare professionals when describing the athletic trainer's role in the management of acute and emergency conditions. Additionally, the musculoskeletal diagnosis and management skill set possessed by athletic trainers further substantiates the need for that skill set within primary care, as 1 of every 7 consultations to primary care is for a musculoskeletal condition. Physicians supervising athletic trainers within ambulatory care settings report being very well satisfied with the musculoskeletal skill set possessed by athletic trainers. Interestingly, physiotherapists in the United Kingdom were able to deliver independent musculoskeletal care within primary care after a brief training regarding interventions for chronic health conditions. Outcomes were good, with patients reporting increased function, decreased healthcare costs due to primary care visits, and those patients appreciated the increased time spent with personally tailored advice. This may be a feasible model for athletic trainers to adopt in a team-based primary care setting. Finally, the therapeutic intervention skills possessed by athletic trainers may serve as a value-adding mechanism to the primary care experience, increasing patient satisfaction and lowering costs. The current trajectory and need within healthcare call for a team-based approach to primary care. This will involve a broad array of skill mix accompanied by careful and accountable task shifting from physicians to mid-level providers, including athletic trainers. The presence of athletic trainers at the point of first contact in many settings calls for a broadened perspective with measured progress by all clinicians. As such, a milestone project for primary care within athletic training is currently underway. The intentional production of milestones within this area will socialize students and learning professionals into primary care and position them for independent clinical interaction for patients with a broader array of clinical concerns and sustain partnership with physicians. In harnessing the specific practice domains of athletic training, the health needs of the population can be addressed at the point of care, and those interventions also transitioned into the community for larger impact. As this project develops, an intentional goal has been established to develop an operational definition of primary care within athletic training practice. The team includes Eric Sowers, Mark Larson, Forrest Pekka, Holly Wallace, DAT student Wade Green, all of these, and Andrew Duckett. Innovative models for athletic training practice continue to emerge. Larson has discussed a patient-centered model for athletic training practice that moves athletic training services out of an athletic department and transitions it towards an independent and interprofessional clinical unit. This is a novel approach that has been adopted by several colleges, resulting in fewer hours worked, direct supervision by physicians, and reported increased recognition of the athletic training profession amongst fellow clinicians. This transition out of the traditional athletic model creates an opportunity not only for collaboration, but for expansion of primary care into the traditional settings in which athletic trainers work. The usual mechanism for accomplishing this in the college and university practice setting has been through student health services, whereas the secondary school practice setting is seeing the emergence of school-based health centers, or SBHCs, with the possibility for contribution by athletic trainers in those settings. Recent work by Noel London, Breitbach, and Ballou demonstrated a 20% increase in the number of clinic visits within a school-based health center, and a change in the perception of the school-based health center when the services of the athletic trainer were included. It is important to note that there are differences in the composition of school-based health centers that may be attributable to socioeconomic status. The treatment of chronic diseases within school-based health centers is projected to save $970 per child when treating conditions such as asthma and diabetes. The inclusion of athletic trainers in school-based health centers may be a far more efficient use of school resources. This is not without challenges and would require a shift in the traditional employment mechanisms of athletic trainers within the secondary school setting. The reason that these transitions out of a traditional athletic training practice model are important is that they provide a structure that is amenable to recognition as a patient-centered medical home. The Patient-Centered Medical Home, or PCMH, was first introduced by the American Academy of Pediatrics in 1967 and has been proposed to provide patient-centered care that reduces costs while creating a sustained relationship between the patient and provider. The National Committee for Quality Assurance is the largest and most well-known accreditation body for patient-centered medical homes in the United States. The NCQA has set forth 6 concepts with 19 competencies that define the criteria that make up a patient-centered medical home. The 6 concepts are team-based care and practice, organization, knowing and managing your patients, patient-centered access and continuity, care management and support, care coordination and care transitions, and performance measurement and quality improvement. While it is true that currently PCPs, PAs, and nurse practitioners can be recognized as personal clinicians under current PCMH standards, athletic trainers can play an incredible role in promoting transition to PCMH status by facilitating team-based care, coordinating care, and promoting evidence-based strategies based on population-specific criteria. Merging athletic trainers, school nurses, and counselors into a cohesive school-based health center is a comprehensible beginning to establishing a patient-centered medical home at the point of care. It is also worth noting that some school-based health centers did not have a physician on site at all times. However, a physician is still expected to have a panel of patients within a patient-centered medical home. Recent work has described the state of patient-centered medical home recognition in school-based health centers throughout the country. The majority of those school-based health centers had no recognition as a patient-centered medical home, and the majority of school-based health centers employed a PCP at less than 1 full-time equivalent. The creative and intentional disruption of athletic training practice within the traditional setting creates an instant interprofessional team that can move forward much more readily, not only in achieving patient-centered medical home status, but also in providing care for a diverse and comprehensive set of needs within the population. In general, as the poverty level within a school increased, likelihood of recognition as a PCMH decreased. It is plausible that athletic trainers may be able to readily benefit from school-based health center revenue through the creative and intentional use of student accident, secondary, and gap insurance policies. While these are typically used traditionally in athletics, these may provide added financial benefit to the school-based health center due to potentially higher reimbursement rates and multiple payers. Athletic trainers have multifaceted experience and skill to directly benefit patient-centered medical home status within traditional practice settings. In order for athletic trainers to respond to the primary care workforce shortage, it's important to understand the historical challenges that the discipline of primary care has faced. The creative and honed skill of the athletic trainer is positioned to have a substantial effect by meeting a need of providing access to comprehensive care throughout the communities where athletic trainers serve patients. In order to help solve health disparities in access to primary care, athletic trainers must continue to utilize our platform of health promotion and prevention in population health to appropriately identify pathology and promote health simultaneously. The comparison of an athletic trainer's scope of practice to primary care attributes is an intentional demonstration of readiness and ability to respond to healthcare needs and create change. This comprehensive paradigm shift will require both clinical and administrative leaders with experience in primary care. The athletic training primary care milestones are the conduit, not only for preparing clinicians to meet the personal healthcare needs of patients, but also for identifying those leaders who are experts in primary care who will innovate and advocate for continued change and new solutions. Thank you very much.